I appreciate it. You're talking now. I told her to keep that short. That was a little tight, apology. A little longer.
I try to go fast.
Well, you did a good job, Rose. Thank you very much. So, welcome. This is my third or fourth time out. And I always enjoy doing live seminars better than webinars, because I hate talking to my computer when I'm doing a webinar. So we're going to spend the next 4 hours talking about I'm sorry? Oh, okay. I'll just talk fast. So we're here to do the compliance update, and really, what a difference does a year make? Okay. Last year, when we got together, we were talking about health reform. We were essentially still looking at what is our 2016 1094s and 1095s going to look like. There have been changes in codes. How are we going to do this? Yeah, we did it 1 year already. We also had the presidential election on the horizon in a month or two after that. And obviously there's been some surprises. The Affordable Care Act, which we'll talk about, and also some new legislation in Massachusetts, which will interest you, which is a new tax on employers. And I'm also going to talk about imputed income, if you're still awake at that point. And imputed income is something that is a topic that comes across my desk probably a couple times a month. And it impacts all of you and all of your plans, particularly your group health, medical, dental, etc. If you offer coverage to domestic partners, or if you offer coverage to divorced spouses in accordance with Massachusetts law, which allows divorced spouses to be on the plan without additional premium, which is a mandated benefit. So that's where that's going to come into play, okay? As far as the Affordable Care Act goes, it continues to be an extremely political animal, yes? It always has been. When it was enacted, it was done without Republican support, and now we got the Republicans trying to change it without Democrat support. There's been a lot of infighting along the way. The Affordable Care Act, as I think the Republican folks have found out, is very complex. It's very integrated into our various laws. It doesn't just sit in one place. It's like webbed into a lot of different things and is far-reaching. It also involves a lot of different public policy issues, which I'll talk about in just a minute. Because it's such a political law, I don't want you to be offended if you're a Republican or a Democrat and I say something that you don't like, because I disparage them all, okay? I truly think that in this case, government is really is a big part of the problem. So we were supposed to start at the beginning in January after the inauguration. They were beating their repeal replace drums. But what exactly are we reforming? Okay, we call it, and I'm guilty of this as well, we call it health reform. We call it health care reform. You see it as health insurance reform. So what is it really that the Affordable Care Act and even Mass Health Law, what are we really attempting to accomplish? And are these terms really synonymous with one another? I don't think so, which I think is also part of the problem. When I think of health reform, I think of wellness plans and eating healthy lunches and school lunches and whatnot. Healthcare reform to me seems more to be the healthcare system and the process. And health insurance reform to me would speak of dealing with insurance carriers and the insurance system. Again, these are not synonymous terms, but we use them interchangeably. And I think that's also part of the problem. The problem also is that reform, and all the reforms that we've seen, is really geared to access. I spent one full-time year at the Health Connector, and was one of their spokespersons that went out across the state trying to educate employers about mass health reform. This was in 2007. And we always went out and said that the mass health care reform bill was an access bill to get more people covered. Okay? It was not about cost. Okay? And that's really the underlying cause of where we are now, is cost. Insurance or coverage benefits are expensive because the cost of care is expensive. Okay? I think everything that we've seen, including the Affordable Care Act, but also the attempts this year to change, repeal, replace, reform, delay the Affordable Care Act, all of those attempts still do not talk about the cost of care, okay, and how to deal with that. So here's the basic policy issues. Is there a right to health care? All right, what's the role of government in health care? Well, we already know our government is involved in Medicare, Medicaid, and the Children's Health Insurance Program. So the next entitlement seems to be, to what extent, if any, should taxpayers, that's us, whether as individuals or as businesses, should we be called upon to fund the health care costs of the low-income folks, but now also the moderate-income folks, okay? And as you see with the difficulty in repealing the Affordable Care Act, that we really have another entitlement growing here, okay? In addition to Medicare and Medicaid and the Children's Health Program, all right? And then lastly, should U.S. citizens be required to purchase health insurance on their own? Should they be required to buy something, to purchase a product, or pay a penalty? Although the Supreme Court said that penalty is really a tax. And really, should the feds have control of about 20% of our economy, which is what the healthcare industry is. But again, to talk about political issues in terms of a right to health care, even the UN has got involved in our health care policy. Shortly after President Trump was inaugurated, the United Nations sent a letter to the Justice Department, or the State Department, excuse me, and they expressed serious concern about the prospective loss of coverage for 30 million people, that in turn could violate the right of Social Security of the people in the United States. That came from the UN. So everyone's kind of getting in on the act. As a matter of fact, there was a Lithuanian doctor who serves as the special UN representative on the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. So you can see, even as far as policy issues, there are even folks outside the United States that would like to have a say in what we do. So here's the current state of the Affordable Care Act. How many times have you heard the ACA is still the law of the land? The ACA is still the law of the land. Breaking news, the ACA is still the law of the land. And it is. Despite, I won't say best attempts, because I don't think that they were very good attempts, to attack the Affordable Care Act over the last 7 years. But even though it is the law of the land, we have the exchanges and the marketplaces that are very, very tenuous. Why do you care about the marketplaces? Because if those folks aren't in the marketplace, they may be in your health plan, right? A lot of times employers don't provide coverage to part-timers. They don't, part-timers might be looking for coverage, but you can say, well, you can go to the marketplace, you can go to the exchange, the Health Connector. Also, employers, you don't see too much retiree medical anymore, but a lot of employers who have early retirees, a lot of them saw, and they weren't eligible for Medicare yet, would have an early retiree medical plan, who some of them were now able to say, well, if you retire early, that's great because you can go to the Health Connector and buy something that'll tide you over until Medicare comes. So the fate of the exchanges, either directly or indirectly, does impact your plans, okay? The IRS continues to struggle, although I hear that they finally got it under control, with the mandate enforcement, okay? Under the Affordable Care Act, we're all required to have health coverage. If we don't have health coverage, on our 1040s, we have to pay a penalty, okay? And as employers, if you're an applicable large employer, 50 or more full-time equivalent employees, if you don't offer certain levels of coverage, or you don't offer to all of your full-time employees, you may pay a penalty. All right, that's the famous $2,000 and $3,000 penalties. But the problem is, no one's seen an enforcement letter. And there was a recent study done internally by the IRS that they're way behind the ball. They've now had 2 years of filings for 2015 and 2016. And now we're getting ready for 2017, and the IRS hasn't contacted anyone or penalized anyone. Okay? But the word is that now they're going to get started. Okay? But again, they're slow. And then Medicaid expansion is a growing problem. And it's a problem for you folks too, as I'm going to talk about in a few minutes, when we talk about the new Massachusetts employer law that's going to take some more money out of your pockets as employers to help prop up our Medicaid program here in Massachusetts called MassHealth. Okay? Now, in terms of the markets that are thinning, the color is what's important here. So you can see in 2016, if you're in a blue or yellow, yellow means you have only, those counties only have one health insurer to pick in their exchange. Okay, blue means you have two, and gray is 3 or more. You can see in 2016, okay, you got some color in there. You see in 2017, the color is even more. We have more and more counties that don't have a good choice of coverages. And in fact, there's 5 states that only have full states, not just counties, but full states that only have a choice of one carrier in their exchanges in 2017. This was done by the Kaiser Family Foundation. This is a projection of what 2018 will look like, and it's effective or as of September 6th. They keep updating it every few weeks. Because it's done by someone different, the colors are a little different. This one's got 3 shades of green, which I don't know why they do that. But the yellow is the important piece, because those are the folks, okay, who have only one carrier, or is projected to have only one carrier in their exchange in 2018. And you can see it's a growing number, okay? And there was just a report, I don't know if you saw it in the paper, Anthem Healthcare has already pulled out of 14 states for 2018, and they're looking at 5 more right now. One of them they're looking at is New Hampshire, but I believe that the indications are is that they won't pull out of New Hampshire. They may pull out of Maine.
But there's no counties that have 0, right?
Well, there's no, you're saying for individuals, if you're an individual and you need to buy insurance to avoid the individual mandate, if you don't have any, well, they're working on that because they haven't had that situation yet. So that was never supposed to happen. Okay, the Affordable Care Act is supposed to create competition, right? And there would be more choices, okay? But I can tell you too that, for instance, Alabama, all right, before the Affordable Care Act, Alabama really only had one carrier anyways. It was Alabama Blue Cross, okay? So the Affordable Care Act hasn't necessarily helped them any. Now, Medicaid expansion is a growing financial problem, and it turns into a problem for you folks, okay? Medicaid was created in 1965, and it was really meant to be medical welfare, okay? For poor women and children and the disabled. That's all that was covered under Medicaid for many, many years, okay? And under the Medicaid program, the federal government writes a blank check, and they share the Medicaid costs with the states, 50-50. So if a state spends $100,000 on their Medicaid program, providing benefits, they can actually count on spending $200,000 because they know that the federal government is going to match that, okay? And there is no limit. There is no roof on the federal match to the Medicaid program. So you can tell it's getting very, very expensive. In addition, because this money is flowing into the states, they don't necessarily have the incentive to be efficient in how they use that money, etc. In 2010, the Affordable Care Act expanded Medicaid. Okay. Now, if you were a non-disabled worker, okay, and you were not elderly, so you weren't going to be in Medicare, and you had income up to 133% of the federal poverty level, which is about $17,000, you could also be covered in Medicaid. All right? So that's what we hear about the Medicaid expansion. Well, that's what they're talking about. Medicaid now insures more than 72 million people in the United States. That's 1 in 5. 1 in 5. Okay? Some states, it's more than that. Guess what? Including Massachusetts. Okay? Where we happen to be 1 in 4. All right? Medicaid is now the 3rd largest budgetary program for the feds. And it's also the fastest growing. Here in Massachusetts, okay, Mass Health covers about 1 in 4 residents. Charlie Baker this year says that they're looking at, very shortly, maybe next year, it'd be 1 in 3 in Massachusetts. And I thought we were one of the better off states, okay? Mass Health, which is our Medicaid program in Massachusetts, is 40% of the Massachusetts annual budget. The budget that was just passed for fiscal year 2018 was $39 billion for the entire state. And Medicaid this year was $14.7 billion here in Massachusetts. Now, the problem is the Medicaid expansion. Because of that, there are a lot of working folks who are now in the Mass Health program. Okay? And the state doesn't like that because they actually think that you folks are cost shifting to the Medicaid program, to the Mass Health program, because why make your plans more affordable, more attractive, when they can just go there to Mass Health, your lower wage workers, and now they're off your plan, right? But it doesn't really necessarily work that way because it's the Affordable Care Act and the expansion that allows them to do that, allows low wage workers to do that. Under Mass Health Reform, which was before the Affordable Care Act, this wasn't allowed, okay, to have low wage workers, if they had an affordable plan available to them from their employer, they couldn't go to Mass Health. But the Affordable Care Act rules expanded eligibility and took away that prohibition of being able to go into Medicaid or Mass Health. And the result now, and we're going to talk about this in a little while, is a new employer assessment on Massachusetts employers called the Employer Medical Assistance Contribution, or EMAC. So anyways, we've been talking about the Affordable Care Act. As you know, the Republicans have been kind of busy this year dealing with trying to repeal and replace, then it was repeal and repair, then it was repeal and delay, and now there's no repeal. Okay? For whatever you think about the Affordable Care Act, that's the bottom line. The American Health Care Act was passed by the House in May. The vote was very close. Considering the 80-plus member majority that the House had, that was really too close to call. But it did pass. On to the Senate. The Senate says, that's nice, but we're going to do our own thing. We're going to call it the Better Care Reconciliation Act. It was pulled a couple of times. Votes were canceled. They finally voted, and it was defeated at the end of July. Again, kind of a close vote. Then they said, you know what we're going to do? We're going to go back to the original repeal and delay bill that Congress passed in December of 2015, and then President Obama vetoed it. They knew he was going to veto it, but we have that bill, which is what some people thought they should have started with in January. Okay? And that bill was defeated. Even though it was passed in, and it was the very same bill, and it was passed in July of 2015. So now they're down to what they call the skinny plan, which was just this bare bones plan. And Congress didn't really want to enact the skinny plan, but they wanted the Senate to pass the skinny plan because it was going to be much different than what the House passed. And so they come together and have a conference committee, and that's where they really thought they were going to put the next health reform bill together. Unfortunately, they lost in the middle of the night, about 2 a.m., 49 to 51. Senator John McCain cast the deciding vote. There's no clear overall philosophy, all right? And there's really no consensus on a solution, and no coherent framework for a replacement. So, what's our future prospects for health reform? Well, the congressional circus is back in town. They came back on September 6th. And believe it or not, there's only 12 legislative days on the Senate calendar in September. Okay, we're all in the wrong business. Okay, so there's not much time for health care reform, and it has to be done. If anything, has to be done by the end of September, because that's the end of the fiscal year. And if they're going to use the filibuster rule, or to not use the filibuster rule, they need to pass it by the end of the month. And it's not to say that the congressional plates aren't full with other major issues, okay? The budget resolution and the border wall were pushed till December. They're still working on federal tax reform. They have to deal with renew the National Flood Insurance Program, which after the 2 hurricanes, I think they're going to do that, right? And they have to renew the Federal Aviation Administration. So there's a lot going on, okay? So what can we expect? Well, one option is nothing. And we may very well get there. Don't forget, the ACA is the law of the land, all right? They could try some regulatory guidance and enforcement where hopefully the IRS, the Department of Labor, or Health and Human Services could ease some of the Affordable Care Act burdens, particularly on employer reporting, all right? Legislation to modify the Affordable Care Act, there's only one proposal left on the table, which is the Graham-Cassidy Amendment to the Affordable Care Act, which we'll talk about in a minute. And there's also bipartisan hearings going on. Today's the last day. They've had 4 hearings, well, today will be the 4th, from the Senate Health, Education, Labor, and Pension Committee, who are holding hearings on how to save the individual markets, how to save the exchanges. And they're hoping that through these hearings, they'll be able to put some legislation together by the end of the year to prop up the exchanges. Okay, so the Graham-Cassidy bill, which is the only one that's left on the table, I call this the Hail Mary pass, okay, because it's still a long shot. It does not repeal or replace the Affordable Care Act. It is only an amendment to kind of reorganize the Affordable Care Act. The crux of the amendment is to take the money that the feds pay now for advanced premium tax credits to people who are in the exchanges, for cost-sharing reductions, which are subsidies to low-wage workers who are in the exchanges to help pay some of their out-of-pocket costs, okay? And the funds that are being used for Medicaid expansion, not the regular Medicaid dollars, but what the feds had promised for Medicaid expansion. Take all those dollars and give them back to the states in block grants, okay? And then say to the states, you do what you want with the money to provide affordable health insurance to the folks in your state, okay? The block grant formula is complex. If you thought calculus was hard in high school, you don't want to look at that. And the block grants reduce over time so that by 2026, or after 2026, all of the Affordable Care Act money that had been sent to the states would be reduced to the point where we'd kind of be back to where we were pre-Affordable Care Act, all right? At least in terms of the federal monies or federal responsibility, okay? In terms of what this plan does, it takes away the employer mandate penalty, okay? Retroactive to the 2016 filing, which is good for you folks. Delays the Cadillac tax until 2026, and it makes some other changes here, including increasing contribution limits for HSAs, and you can use an HSA to buy something in the individual market. Right now, HSAs can't be used for premiums except for COBRA and whatnot. So we'll see where that goes. It really is a long shot. Just yesterday, Senator Rand Paul came out and says, I can't support this. All right, so we're already down to 51 senators. We need 50 if they're going to pass this with the vote of the vice president, all right? So in other Affordable Care Act news, the IRS has now released the forms that are used to report to the IRS as to whether or not you're meeting the employer mandate. And how many folks here have 50 or more full-time employees and you do the filings? Okay. So if you were hoping that this was all kind of going to go away in one form or another, the IRS has released the forms and now the instructions for the 1094 and the 1095, Bs and Cs. And they've also released back in the spring a couple of information letters that basically said the Affordable Care Act is the law of the land, it's a part of the statute, and it's going to remain in force, so that's our opinion, unless it's changed by Congress. All right. The only thing that's going to happen now is if the Graham-Cassidy bill would pass, it would take away the penalties for this. All right. I'm sure none of you pay penalties anyways because you have Sylvia as your broker. So don't bank on a reprieve, okay, from the filing requirements until you see something else. Now, it is possible that the IRS could issue a delay and say you don't have to file by the end of February or the end of March. They may delay it. They may take a no enforcement policy, which means you have to file, but there aren't going to be any penalties. There are still things that can be done. We'll just have to see where it goes. They've also released the affordability rates, okay, for next year. This is, when we first started, under the Affordable Care Act, your coverage needs to be affordable, which is in 2017 meant that the employee contribution for single-only coverage couldn't be more than 9.69% of their income. In 2018, this is the first time that the contribution rate for employees actually falls, okay? It was increasing right up through 2017, and now we're basically going back to what was almost a 2015 level, okay? So if you have set your contributions very, very close to the 9.69 rate, you may have to jigger those and actually reduce employee contributions a little bit to come under or equal the 9.56 rate. If you had a wide margin, then it probably wouldn't be an issue. The health insurance tax, which is a tax on health insurers that they pass through to you, okay? They took a break, believe it or not, and they did not have the health insurance tax in 2017. They had it in 2014, 2015, and 2016. It now comes back in 2018. That'll be about a 3%, alone is about 3% of your premium. Okay, so it's passed through. Also, the carrier deadline to participate in the exchange is usually done in June. It's been passed off or pushed back till July, to the 27th of this month, which is a drop dead date for the carriers to say whether they're in or out of the exchanges next year. And they also have to get their rates together as well. Also, before we get to Massachusetts, yesterday, Senator Bernie Sanders introduced his Medicare for All bill. Okay. Now, the story goes that although it's been introduced, no one really expects it to be passed with a Republican Congress right now. But they're starting to set the table. And I can, just to give you a little idea of what's on tap for that, it was introduced yesterday with 15 co-sponsors, and it would, every U.S. household would receive comprehensive coverage in a publicly funded program. The transition to Medicare for All would take place over 4 years. So in the first year, it would be adults 55 and older, and children are always covered up to age 18. In the second year, it would go to adults 45 and over. In the third year, it would be available to adults 35 and over. And in the fourth year, everyone would be covered. There would be a universal Medicare card that you would hold. The annual price tag is, well, they don't have a price tag, but when Bernie Sanders was campaigning, he had estimated the price tag annually to be $1.4 trillion. It would be funded in part by a proposed new 2.2% income tax on all Americans and a 6.2% levy on employers, and then they would also seek additional funds from the wealthy. Okay? So that's also on tap. All right? All right. So I've been kind of setting the table for the Employer Medical Assistance Contribution, also known as EMAC, here in Massachusetts. Okay? Now, you pay the EMAC now, okay? But the EMAC has been supersized. Supersized me, okay? So, in January, when the governor proposed his budget, his budget proposal said we need this employer contribution to health care because we have a $600 million shortfall in the Mass Health program over the next few years, and we need to bridge that gap. So in order to address the rapidly increasing health care costs, which he attributed to cost shifting from the private sector to Mass Health, which was only being done because the Affordable Care Act allowed that, he proposed that we kind of have the old-fashioned fair share contribution again, and it would apply to employers with 11 or more full-time equivalents, and the penalty for not complying would be $2,000 a year per full-time equivalent employee for those non-compliers. What the governor actually signed in the beginning of August is a 2-year, two-tiered assessment on employers expected to raise $200 million in fiscal year 2018 and $200 million in fiscal 2019. And it involves the expansion of the current medical assistance contribution. Okay? Now, the medical assistance contribution, I think we'll get that into a minute. So what happens is, right now, the EMAC is assessed on the first $15,000 of wages. So right now, for your employees that you're paying at least if you paid at least $15,000, it's $51 a year is what you're paying now for the employer medical assistance contribution. With the changes, it'll now go to $77 an employee. Not necessarily a big deal. But the new part is a new targeted assessment, again, on employers under the EMAC to pay up to 5% of an employee's wages if you don't comply. Okay, comply with what? I'll tell you in a minute. Okay. Now, there was supposed to be, the governor had kind of reached an agreement with business leaders in Massachusetts in June where they accepted part of this, but there would also be reforms to the Mass Health program so we wouldn't have this problem again. Okay. In the end, those reforms did not make it into the legislation. The governor kicked it back to the legislature again. He signed the rest of the budget, but did not sign this piece. But in the end, this is what he signed, okay? And there are statements of commitment by the governor and the lawmakers in Massachusetts to get to health care reforms, mass health reforms, this fall, early next year. Again, the EMAC is a payroll tax paid by employers to finance the cost of subsidized care for low-income residents. The EMAC is relatively new. It started only in January 1, 2014, okay? And it was enacted as part of the whole repeal of the Mass Fair Share program, which was repealed because we were getting ready for the Affordable Care Act, okay? And the employer mandate under the Affordable Care Act. And they also got rid of the Medical Security Program, which was the medical coverage that was provided by the Division of Unemployment Assistance when if you were unemployed and you didn't have any other medical coverage through COBRA or any other place, the Division of Unemployment Assistance had a medical security program. So fair share contribution went away, medical security program went away, and EMAC was enacted, okay? And again, the contributions are paid on the first $15,000 of each employee's wages based on a rate. And EMAC applies to employers who have an average of 6 or more employees in a quarter, because we're on the quarterly system, okay? And this is phased in over 5 years. So if you're a very small employer and you finally hit the 6 employee level, it's phased in over a number of years. And actually in the first 3 years, a really, really small employer who just hit 6 or went over 6 would not pay the EMAC for the first 3 years, all right? So in years 1, 2, or 3, if you are newly subject to the EMAC, you're exempt for the first 3 years. And then these are the rates currently in 2017, and you can see that the rates are bumped up under the new EMAC proposal. Well, it's not a proposal, it's a law now, okay? Employers have to file their quarterly employment wage and detail reports. And the penalty is 12% interest if you're late or you don't file. It's 12% interest accrues from the due date of the quarter until it's fully paid, which is basically the same penalty that's used for unemployment insurance, okay? Now, the question is, what is this new targeted 5% deal, okay? We know it's an assessment, we know it's 5% of employee income, and it's targeted to employers who have employees who are getting medical assistance from the state. Now, regulations are due to be proposed by the Division of Unemployment Assistance, who runs this, with the assistance of the Health Connector, okay? Those proposed regulations are not out yet, okay? So this is the actual text from the statute. I just broke it up into 3 bullets, okay? But this is just a run-on piece. So each employer, except those who employ are under 6, shall pay a contribution for each employee who receives health insurance coverage through the Division of Medical Assistance, that's MassHealth, or subsidized insurance through the Commonwealth Health Insurance Connector Authority. That's the Connector Care coverage with the tax credit, okay? The contribution shall be computed by multiplying the wages the employer paid any such employee by 5%. Okay? And that works out to $750 per employee for the year. Okay? So the question is, what about part-time employees? If I have a part-time employee and they're in MassHealth, do I have to pay $750 for them? For that one employee? No one. It's really not clear at this point, which is why we need the regs. Okay. And there are obviously other issues as well. Because you're doing this quarterly, how long does an employee have to be on MassHealth before you get dinged? Is it 1 quarter, 2 quarters? Again, these are the, you pass the law and everything else is details. So that's where we are with the EMAC. Is there any questions on the EMAC?
Is the $750 a max or a minimum?
Max, because it's 5% for the first $15,000 of income, and that's $750.
One question.
Yes.
And when there's 6 employees, is that full-time equivalent employees?
No, it's an average of 6 bodies.
Is there a date?
Unless they, I'm sorry,
No.
unless they have regulations or whatnot that modifies that. But where it sits in the statute, it would be bodies. Yes.
Is there a date set for promulgation of regulation that would clarify the point about the part-timers?
Well, earlier versions, when the budget was going through the House and the Senate, the Senate had put in language in their budget that there would be public hearings on this, whatever the rule was, by October 1, which meant that the proposed regs would have had to have been issued before October 1. They have to be out there for a certain period of time before you have the public hearing, okay? To be finalized, the regs to be finalized by November or something, which is still not a lot of time for an employer to get their arms around it. Not the other piece, but this piece in particular.
Right.
But that didn't make it into what the governor signed, but at least that's what they were thinking. So, I try
The
to.
employment lawyer is saying it's an unsettled question. It's definitely an unsettled question.
It's an unsettled question.
Okay, thanks.
Sure. All right. So now, any other questions on EMAC? Yes.
So we've kind of looked at this, we're on a self-insured plan. So we're looking at it and saying the $750 is actually lower than if we had to bring these employees onto our plans.
Sure. That's an economic decision. Employers make those kinds of decisions. Economic decisions, risk benefit, a lot. dealing now with a home health care agency who've finally hit 50 last year, and they are, so they're subject to the Affordable Care Act this year and the penalties, and they have no health insurance coverage. And so now they're trying to figure out, well, what do we want to do for 2018 and whatnot. Now, they're fully exposed for 2017 because they have no health coverage offered at all to their full-timers. But they're also sitting down and saying, well, you know, how many full-timers do I have, and what would the penalty be? And under the A-tax penalty, you get your first 30 full-timers free. So how many full-timers do I really have over 30? And it just cost benefit, yes, sure. So as I mentioned at the beginning of the program, this question comes across my desk a couple, 3 times a month. And I did a bulletin on this, and it's in your folders in the back. I did it for the Mass Association of Health Underwriters, and it was just an update bulletin that kind of describes this in non-PowerPoint language, but should be, so you can look at that as well. All right? Imputed income. What's imputed income? It's a non-cash fringe benefit. All right? That's included in gross income. And the income is the value of the service or the benefit that's provided by you, the employer, to your employees. Okay? And that imputed income is treated as income, it's taxed as income, and it's put on the W-2. Okay? So it affects your W-2 reporting. So why do we have imputed income? All right? Because employer-paid health coverage is a fringe benefit. And the general rule under the Internal Revenue Code, and I know this will shock you, is that everything is taxable unless it's not. Okay? So the general rule is if you get anything from your employer, and this applies to everything, but we're talking about employer-based coverage here, or benefits. Anything that your employer provides you on a non-cash basis has a value and it's taxable to you as an employee, okay? Unless it's excluded, there's a special exclusion that says, nope, that's tax-free, okay? The value of employer-paid health coverage, okay, that's the employer's contribution, okay, for employees, spouses, and dependents are excluded from the employee's gross income. It's tax-free. Matter of fact, the health insurance exclusion for employees is the second largest revenue loss for the Internal Revenue Service. The first one being the mortgage deduction expense. Okay, but this is number 2. Okay, nowhere in there do we see domestic partner. Nowhere in there do we see ex-spouse. Okay, so everything's taxable with regard to health coverage, medical, dental, vision, medical FSA, HRA. Okay, the value of the employer-paid health coverage that's for the employee, the spouse, and the dependents is not taxable. It's free to the employee. So why is that? Where's the big disconnect on this? Okay, and that's because we have a group health plan that has an eligibility provision in the group health plan, and it says, hey, you know, we do the employee 30 hours or more per week, spouses, you know, children up to age 26, handicapped children, and domestic partners. And Massachusetts has a mandated benefit that's in your group insurance policies. It may be even followed by a self-insured plan, voluntarily, that says that if an employee has an ex-spouse, if the divorce decree requires the employee to cover the spouse, the ex-spouse, the employee can put that or keep that ex-spouse on the plan without additional premium. Okay? So you had family coverage, you had a wife and 3 kids, or a husband and 3 kids, you get divorced, now you have an ex-spouse and 3 kids. Okay? You paid family coverage, you paid the family rate before, you're paying the family rate now, so there isn't a whole lot of change to the coverage, right? And that's actually a big problem, because a lot of, I don't know if you find this, that sometimes you don't hear about the divorce, right? And there's really no change to their coverage. But that group health plan definition does not match the exclusion under the federal tax code for everything's taxable unless it's not. Because the only thing that's excluded is for the spouse and dependents and the employee. Okay? So that's the disconnect. So you have an eligibility provision in your group health plan that exceeds the tax exclusion under the Internal Revenue Code. All right? Domestic partners. All right? Now, in domestic partners, you would impute income for both state and federal tax purposes. For Massachusetts, for divorced spouses, it used to be that you would impute for both federal and state taxes. But since 2009, with this Mass Department of Revenue directive, it basically says, because this is a mandated benefit, the divorced spouse coverage is a mandated benefit, that we're not going to tax the employee under state law. All right? So domestic partners, imputed income for federal and state, Massachusetts, just federal, just to make your life complicated. Yes?
Yeah, we had a real difficult time doing business with the city of San Francisco a few years ago, and Julie was really helpful working with us trying to get all the language down because of their requirements on domestic partners. They have really unique requirements, and we went around and around, and it took us like 3 years to get everything done. And eventually, they ended up changing their rules so that we're now eligible, vendor for the city of San Francisco. But it sounds like even now, there's still that bias because the IRS is going to tax people.
That's right.
Even though the employer can give them health coverage, there's still an actual bias against it.
Yes. Yes.
What's also interesting is when they passed the ACA and they extended children all the way up to their 27th birthday as eligible under the health plan, the IRS did acknowledge that.
Yes, when the extension went to, it's actually the end of the year of your 26th birthday. Although most employers just do the month of their the end of the month of their 26th.
Coverage ends at their at the birthday or the end of that month.
Right.
But because your tax year is a calendar year, the IRS
right. They extended it all the way to give employers flexibility. So when the federal government extended coverage to age 26, it also changed the tax code to say a dependent to a child to age 26 would be excludable from coverage, okay, from income tax, which they were very smart to do, quite frankly. So what's fair market value? Because that is what is used to impute income. It's the fair market value. And the IRS regulations say that the fair market value is the amount the individual will pay in an arm's length transaction. Okay? And if you can't, fair market value is not affected by the relationship that exists between the employer and employee. Meaning, well, we have a group plan and whatever, and we can, we get our insurance cheaper and whatnot. You can get a cheaper cost. It's cost, not value, because you work for us. So they say you disregard the employer-employee relationship, has to be an arm's length transaction, and whatever the employer incurs for the cost doesn't necessarily mean it's fair market value, okay? Has the IRS ruled on what's fair market value? No, because they call it an inherently factual matter, okay? Now, there are some revenue rulings that are out there where certain approaches were used. They didn't rule on those approaches, but they didn't comment on them either, saying, we don't like that. So we as ERISA lawyers hang our hat on that, all right? When you determine fair market value, today, you have to, everything pretty much for medical is paid pre-tax, right? So you have the employer contribution, and then you have the employee's contribution on a pre-tax basis. Under the 125 plan rules, really, the employee's contribution, salary reduction, premium conversion, is really, under the tax code, counted as employer contribution. So if the employer contributes $100 for the month and the employee contributes $100 pre-tax, under the hocus pocus of the 125 rules, the employer has contributed $200, okay, towards the cost of the health plan, which means, so you have to be careful that when you're looking at cost, that you look at both pieces, or basically just remember that in most cases it's the entire premium, not just the employer's piece of it. There's no formal guidance on fair market value, and there's some different approaches that have been used by employers. There's incremental cost, okay? I put someone on the plan and I have to go from individual to family. What's the difference? You'll also, the biggest one is, I have family coverage now and I put my domestic partner on, I still have family coverage. So there's no incremental cost, right? Well, that doesn't work because it's not an arm's length transaction. It has nothing to do with the cost of the coverage and the rest of the IRS regulation. Okay, some people used to use a per capita allocation, which meant if you had a family plan, you had 7 people on it, you divide the premium by 7 and that would be the imputed income, right? That's a great deal for someone who had 7. What if you only have 3 people in your plan, in your coverage as an employee, and you have to impute income, and you divide that same family premium by 3, they'd have more imputed income than the person that had 7 people in their family. So that really doesn't work either. This is the one I recommend. This is the one that's been in a couple of private letter rulings from the IRS. They did not trash that one, but they didn't say it was okay either. But it's what most folks use, which is essentially the COBRA premium, okay? So you have an employee, they put the domestic partner on the plan, and they go to employee plus 1, or maybe family if you don't have dual dependent rates. And they have to pay that premium and their contribution, but in addition, the value of that coverage has to be imputed to the employee. So you use the COBRA rate. That does not mean the employee pays a COBRA premium. It just means the employee pays the tax on the COBRA premium. Okay? The COBRA premium is used as the measure of value of the coverage provided to the domestic partner in my example, because it's a fringe benefit that's provided to the employee. We're going to cover your domestic partner, but that eligibility does not match the tax code exclusion. All right? And if you say, look, this is stupid. I haven't been doing this, and I don't, and I just think that this is mumbo jumbo. It's hogwash. Okay, I haven't been doing it. No one said anything. You will also find it in the cafeteria plan regulations. Okay, and the cafeteria plan regulations basically say that accident and health coverage okay, medical coverage, purchased for someone who's not the employee spouse, or dependent, must be elected as a taxable benefit, okay? Employer-provided coverage for an employee, his or her spouse or dependents is excludable from the employee's income. The fair market value of the coverage for any other individual provided with respect to the employee is includable in the employee's gross income. So if you have a Section 125 plan, which I know you all do, all right, if you take the hogwash approach and you don't want to do this because you think it's too much work or whatever, you will now find that you have what the IRS calls an operational failure with respect to your Section 125 plan, which means they could undo your 125 plan for everybody. Okay? The tax benefits. Any questions?
Yeah, just one.
Sure.
What about long-term care insurance premiums for employees? How does that fit?
Long-term care insurance premiums are generally not done pre-tax, and I think there's a prohibition for that. And employer contributions to long-term care, there's a formula that's used. Only so much of it can be excluded from the employee's income under 213 of the code, which is the medical expense piece. Okay? Oh, you mean for imputed income purposes?
Yeah.
It would. I would imagine it would be imputed.
It's the one coverage really that's allowed to be offered on a discriminatory basis within your organization. So we're not talking about owners, but any W-2 employees of the corporation who receive long-term care benefits that are paid for by the company are not taxable to the employee, and they're tax deductible to the employer.
Okay.
So-
Did you have your hand up?
Yes, just a clarification on the 2% COBRA rule. So if there's a domestic partner on the plan,
Yeah.
are you basing that on the single rate of the COBRA?
Sure.
Okay.
Yeah,
Not
because,
family.
right,
Okay.
no, not family,
Okay.
no.
Okay.
And it's the COBRA rate without the 2%. I mean, you're just looking at the value of coverage. It's like saying, do any of you folks impute income under your group life insurance program? Yes. Okay. Some of you do. It depends how it's set up and how much you offer and everything else. But there's an actual table in the IRS regulations that you use to figure out what the value of the group term life insurance is. It has to be imputed. So we don't have that kind of table for this, but still you need to deal with the value of this fringe benefit that's not excluded by the tax code.
Rick, can I just ask, on the Section 125, the premium deductions for employees, if someone has a domestic partner on the insurance plan, so they're enrolled in a family plan, do we still advise our clients to take the full pre-tax deduction in that case?
Yes. The reason being is that the rule basically says that it's the value of the employer-provided coverage, right? And not received by the employee that the employee hasn't paid for on an after-tax basis. Okay, so early on, some employers were trying to split the premium and say, we're going to contribute this, and if you have a domestic partner, you're going to pay that additional premium on an after-tax basis. Payroll was going, oh my God. But don't forget that increment isn't necessarily fair market value, first of all. And second of all, if you do it all pre-tax, okay, by imputing income, you're basically dealing in taxing that imputed income. You save yourself the trouble of trying to bifurcate the the contribution and the premium amount and whatnot, and it all comes out in the wash essentially. Okay.
Another question concerning, health savings accounts. An employer contributes to a family health savings account. And that, so that's going into the employee's, personal, health savings account.
HSA, yeah.
Does that also have to be, factored into this imputed income, that contribution?
No, contributions to an HSA, you would not have, imputed income on the contribution, okay? Now, you have your HSA, and right now, there's no employee and spouse joint HSAs, not yet. I think we might be getting there. So it's the employee's HSA. Money goes in, okay? Now, what is the HSA supposed to be used for? Medical expenses under 213 of the code and everything else, right? So you can use expenses for you, your spouse, your kids, whatever. You can even use it to buy a flat screen TV if you want, but you're gonna get dinged on that, right? You're gonna pay penalties and whatnot. So when you go, if you pay an expense that's for a domestic partner, that expense it's taxable. Okay, so that's where it comes in. Anybody else? I just have a couple slides left. You've been great. So we're going to go back to Massachusetts and talk about minimum wage and paid family leave, medical leave. As you may know, there are two bills currently in the Mass legislature. They are for the paid family and medical leave. It's Senate 1048 and House 2172. If enacted, would require employers to provide paid family and medical leave. Okay. And earlier this year, in January, both of those bills got parked in their respective committees. And they haven't really seen the light of day since, although I think one committee held a hearing in June. Okay? Some people, and I don't know what's going to happen to that. Some folks got a little impatient and they said, I know what we'll do. We'll take that language or the parts of the language that we like and we'll get some signatures and we'll create a ballot initiative. And we'll get it on the Massachusetts ballot in November of 2018, not 2017. And we can all vote on it. And actually, that's how the Massachusetts Earned Sick Time Law was done, right? The lawmakers were puttering around, and someone created a ballot initiative. They got enough signatures, it was certified, and next thing you know, it was passed as law, and it kind of read like a statute, except it had all kinds of holes like Swiss cheese in it, and the AG had a devil of a time, the Attorney General had a devil of a time doing regs and whatnot for the Earned Sick Time Law in Massachusetts. So now someone said, well, hey, that worked. So we want to do paid family and medical leave. Let's do a ballot initiative. The Attorney General on September 6th just certified that to go forward, to be put on the ballot for the November 2018 election. Now that doesn't mean that the House and Senate couldn't push their bills along if they wanted to between now and then. They're certainly not dead, or they may say, heck, we don't want to take the flack from this or whatever, we'll do it that way. Basically, it provides, as it's written now, as a bill, it provides 16 weeks of family leave or 26 weeks of medical leave, paid, all right? The family leave is to care for a new child, or to address, your serious health condition, or care for a seriously ill family member, or it has a piece too if you're dealing with your family member's active duty military service. The benefit for paid family and medical leave is 90% of average weekly earnings, up to $1,000 a week. Okay? The employer contribution for this is 0.0063 of each employee's annual wage, and the employer, if it wishes, can share up to half of that with the employee. So you could say, okay, we're going to do 0.0032, and we're going to ding you on your paycheck every week for 0.0031. So you can you can share it if you want. The contributions would be placed in a hermetically sealed bag. No, they'll be placed in a disability trust managed by the Commonwealth of Massachusetts. Okay. Also, those returning from leave will have job protection, benefit protection, and pay protection. Okay. The Associated Industries of Massachusetts, that's AIM, estimates that the annual per employee cost to an employer would be about $520 for this program as written, if it were to be enacted either by the legislature or through a ballot initiative. Okay? All right. I would also say that if something like this comes into effect, like we have FMLA now federally. Massachusetts does not have a state version of FMLA. But even with FMLA, we often have problems with short-term disability, the Massachusetts parental leave loan, if you're not covered by FMLA. There's a lot of overlapping, so this would be another layer. They need to integrate this somehow as well. Finally, there's a minimum wage proposal that has also been certified by the Attorney General on the same date to be put on the 2018 ballot. Currently, we're at $11 an hour, and they would step that up over 40 years to $15 in 2022. Okay? Ballot initiative. So even if it passed the ballot initiative in November of 2018, it's going to jump right away in 2019, just less than 2 months later. All right. So that's what we had. Stay tuned. Continues to be an interesting ride. As I told you last year, and the year before, and the year before that when I was here, this will not be your last seminar on healthcare reform, and that certainly remains true today. There's nothing to say that something might not wind up or show up next year as well, but this is the state of our healthcare reform in both on the federal side and on the Massachusetts side. And again, stay tuned. I know Sylvia puts out bulletins and updates. I sometimes help provide some of those. Just stay informed. It's been a wild ride. It's going to continue to be a wild ride. All right? Thank you very much.
Thank you.